Good morning, everyone. I think everyone's got breakfast now. Thank you very much for turning up for the breakfast session. Very kindly sponsored by Heron Therapeutics, so thank you very much. They've been very supportive to the Society. I think you're all aware that opioid-sparing analgesia is one of the main pillars of ERAS, and there's lots of new and exciting opportunities out there. And we've got a very eminent speaker, Philip Shaddock, who's Chief of General Surgery. So it's nice to have a surgeon speaking about analgesia, because although we get a lot of anesthesiologists talking about analgesia, it's surgeons that often have to pick up the analgesia issues once the patient's discharged home and got any issues. So Philip's going to talk to us about entering a new world of post-operative pain management. Thank you very much.
Good morning. Thank you for being here. I know it's early. I appreciate you being here. The talk only takes about 30 or 40 minutes, so we've got plenty of time. And at the end, there's time for discussion. Even if during the presentation you guys have questions or comments, feel free to jump in. I'm a general surgeon. I'm in Durham, North Carolina. My practice is primarily GI and hernia surgery, and we'll show some hernia data in this presentation. I started consulting to the company about 2 or 3 years ago on clinical trial design, and I was a PI on one of their trials, and that's how I got involved with the product. This is a non-CME talk. This is a sponsored talk this morning. The deck was put together by Heron. It has a number of requirements for compliance with the FDA. You're going to see a bunch of slides in here that have cut and paste FDA language, and it seems kind of onerous, but it's there for a reason. The unmet need, I don't need to explain to this audience. Normally I talk about how our surgeries cause pain, especially the first 3 or 4 days, often moderate to severe, how our local anesthetics don't last long enough to address that, hence we get into the opiates and how do we reduce that. So for this audience, I'm not going to go through this because these are issues, for which you guys are here and for which this meeting exists. The product is brand new. It was approved by the FDA the end of May. It was launched in July. So it's only been out a few months. Most of you probably haven't seen it or used it yet. Probably a lot of you don't even have it on your formulary yet. It's a brand new product. When it was initially launched, these were the indications: post-surgical analgesia for 72 hours for the 3 indications of bunionectomy, open inguinal hernia, and total knee. Those were the data that were submitted to the FDA, and it was approved for all of those. You probably also know, though, this was launched in July, but in October, the FDA and Heron jointly released a statement that said they're in the process of expanding the indications, and that's probably imminent in the next couple of months. So what you'll see, and this is all public information, you can read the announcement online, but basically it says that for abdominal surgery, it's going to be the indications are going to be expanded to small and medium lengthened incisions, and in orthopedic surgery, it'll include not only total knee, but hip, knee, foot, and ankle. So again, you can read those statements. 4 things to talk about this morning. The first is the mechanism of action, which is different for this product than any of the other extended delivery products or devices that we have available. I'll explain why that's different. The second is how we deliver it. This is a thick, viscous product. It's not injected through a needle. It's just placed into the incision, so we'll talk about delivery. How many surgeons in the audience today? About half a dozen or so. How many anesthesia staff, docs and CRNAs? About equal, okay. Nurses, a fair bit also? About a third. Okay. Are there anybody in the audience that are non-general surgeons? What fields? Say it again? Okay. Okay, good. Okay. Third thing we'll talk about today are the data, and that's actually the bulk of the talk. We're going to go through, there are 9 studies. This has been studied in 9 different trials, and I'll show you that data, and that's the bulk of what we're going to work through. And then at the very end, just a couple of comments about cost and reimbursement. So mechanism of action. So we have other extended delivery type products. What's different about this? There are 2 different features about this product compared to anything else out there. The first is the absorbable polymer delivery device, and the second is the presence of a low-dose meloxicam in the product. The polymer is a dissolving polymer. It's been used for other indications. It's not new for this particular application. The active drugs diffuse out of the polymer over about 72 hours. About 50% of the active ingredients come out in the first 24 hours, about 80% by the end of 48 hours, and about 95% by the end of 72 hours. The polymer then dissolves into water-soluble products or excreted in the urine between about 3 days and 3 weeks. The yellow in this picture is the meloxicam. So this is basically a bupivacaine product, but it has a very low dose of meloxicam in it, and that's really the key that makes it work. Why is that? Again, the anesthesiologists in this room know this better than the surgeons, I'm sure, but basically the amide local anesthetics are delivered at the surgical site. They act locally. To act, they have to get in through the cell membrane of the neurons. To do that, they need to be non-ionized. So in physiologic pH of about 7.4, they get in pretty well and work pretty well. As the surgical site becomes acidic, which it does in the first 24 hours and stays for another couple of days, it becomes acidic due to cutting blood vessels, suturing tissue together, tissue compression, the inflammatory mediators, especially with the polys and so forth. But the bottom line is the surgical site becomes acidic. In the early development work with this product, the developers were working with different polymer delivery devices, different amide local anesthetics, and they couldn't get their amide local anesthetics to work beyond about 24 hours. Even though they could get them to deliver beyond that point, they didn't show benefit. So then they started working with the issue of the pH and trying different non-steroidals. And so in the development work, they actually put pH probes in the animal model and measured the pH of the tissues next to surgical incisions in animals. And it drops from about 7.4 to the high 5s, about 5.8 or so, 5.6, 5.8 in the first 24 hours. And then it stays in the high 5s for the next day or two. If you put a very low dose of non-steroidal at the surgical site, it doesn't work systemically. We'll talk about that in a minute. But if you put a very low dose at the surgical site, it maintains that pH at about 6.5 or 6.8, somewhere in there. And by keeping the pH in the high 6s as opposed to the high 5s, you maintain much better effect of your local anesthetics. When the pH is down in the 5s, the local anesthetics lose about 90%, 80-90% of their activity. In the high 6s, most of that's maintained. So the purpose of the meloxicam in the product is to have a low-dose anti-inflammatory response. We were talking about that a second ago before this, but a low-dose anti-inflammatory effect. And so different non-steroidals were tried. Titration studies were done at different doses and different ratios, and the end result was what's in the product, which is a very small dose of meloxicam. But it's enough to maintain the pH in the mid to high 6s and maintain most of the activity of the product over 72 hours, which is why other devices can deliver local anesthetic, but they don't seem to show much benefit beyond about 24 hours. This is different. This is the animal data, pig model, flank incision, von Frey filaments, standard animal model for measuring pain. So the y-axis here is pain control, high is good, the x-axis is time. So if you give the pigs placebo, which is the gray bars, they have no pain relief. If you give them extended relief bupivacaine, but without the non-steroidal, they have some pain relief, kind of degrading over the first 24 hours a little bit. If you give them extended release meloxicam without the bupivacaine, it basically does nothing. But if you take that same dose of meloxicam and put it with the bupivacaine, you get that amount of pain relief. And the big difference especially is in the second 24 hours and the third 24 hours, which is when the surgical site would be acidic otherwise. So that's the mechanism. So that's the model that was used during the titration studies and the development work. It was then carried into humans on open inguinal hernia incisions and bunionectomy. And these are the data from the human trial. So the yellow is extended release meloxicam, the light blue is extended release bupivacaine, and then the purple is the combined. And so what you see, if you give extended release meloxicam by itself, it does nothing. If you give extended release bupivacaine, it does some. But if you add a very low dose of meloxicam, the bupivacaine works better, especially in the second 24 hours and the third 24 hours. So that's from a human study, hernias. This is basically the same study done in bunions, same effect. So that's how they got to the mechanism of action and the synergistic effect of having a baby dose of non-steroidal along with the bupivacaine. One of the questions that often comes up, and I would expect it from the anesthesia colleagues in the room, is a dose. You know, it's basically two questions. One is the difference in clinical effectiveness a dose issue? Because the anesthesia staff know that the dose of aqueous bupivacaine is 1.5 to 2 milligrams per kilogram, or about 150, 175 milligrams max, right? And this product uses about 300 to 400 milligrams. So one question is it just a dose response difference? Another question is that a safe dose to give? It's, you know, twice the max dose. But if you look at the absorption profile and the plasma levels, it's very different. Aqueous bupivacaine is absorbed and present systemically within the first couple of hours. This product releases the drugs by diffusion continuously over 72 hours. So if you look at the gray bars, This is the open inguinal hernia study, the total knee study, and some early work done in plastic surgery. The gray bar shows you that the plasma level of the bupivacaine is about 200 nanograms per mil in the hernia study, which is a 300 milligram dose. It's about 500 nanograms per mil in the total knee study, which is a 400 milligram dose. What does that mean? Toxicity occurs at about 2,000 to 4,000 nanograms per mil. So we're seeing levels here with these 300 and 400 milligram doses of product that are roughly a tenth the toxic dose. So even though it's a 300 or 400 milligram dose, because it's continuously released over 72 hours, you don't get any high peaks. Second thing, administration. So for the surgeons, very viscous product. It's thick, it's light yellow, it's sticky, it's almost indistinguishable from honey. If I gave you a syringe of this and a syringe of honey, you'd have a hard time telling them apart. And so it's not injected through a needle, so you don't inject it like aqueous bupivacaine or liposomal bupivacaine. It's just placed in the incision. So you do whatever operation you're doing. When you're all done with your operation, you irrigate, confirm hemostasis. Right before you reach for your closing suture, you take the product and you squirt it into the surgical site, let it spread out over the tissues, and then you go ahead and close. Takes 15, 20 seconds, whatever. But it's just placed into the surgical site. It's the last step before soft tissue closure. So what does that look like? So this is the cartoon. And this is what it looks like in an open inguinal hernia repair.
Hello and welcome. My name is Tim Beard. I'm a surgeon in Oregon. And I'd like to talk to you today about application of a new compound called ZynRelief. It's used for postoperative pain, and we're going to show you a short video on how to apply this product. I was part of the research studies with this product, so I've used it in over 20 patients. So I have quite a bit of familiarity with how to apply the product. So as we start the video, this is an open Liechtenstein hernia repair, which we're all familiar with. The procedure's been pretty much done at this point. You can see the mesh is in place, the spermatic cord's to the patient's left, and now we're placing the ZynRelief in over the mesh that's been placed for the Liechtenstein repair. It's important to cover every surface area that you can with the product, as that's what really makes it useful. It's a thick liquid, almost like honey. There's no needle at the end of this syringe. It's a blunt tip applicator. So it's just placed in. You kind of push it around to make sure and cover everything you can. I think it's really important to place it medially as much as possible, as that's where a lot of people have a lot of pain after hernias. But you just want to cover this layer as best as you can. The total in the studies, we used about 10.5 milliliters of the drug. I use about 5 to 5.5 milliliters in this layer, which is below the fascia of the external oblique, and then the rest on top of the fascia of the external oblique. So now you can see they've moved on. They've closed the fascia of the external oblique. You can't really see the mesh anymore. And now we're going to place the other 5 to 5.5 milliliters of the ZynRelief in this layer. Again, you're trying to cover everything possible that you can. This takes 15 to 20 seconds to put this in. It does make the instrument sticky, so we tend to wash the instruments off before we just send them to sterile processing so they don't have any of this compound left on them. But very simple to put in, very easy to put in, and once you're done, you can close whichever way you normally close your incisions. I personally use a monofilament absorbable suture, such as monocryl, to close my incisions, but whatever way you're comfortable with, you can close. They're just about finished putting all the rest of the product in, and you're going to see that they'll close, and then the procedure will be done. So the whole really shouldn't add much time at all to your procedure putting this in, and once you've done 1 or 2, it'll be very straightforward and easy. So I hope that helps, and good luck.
Of my surgeons, how many are orthopedic surgeons? Anybody? All right, so I'm not going to show the ortho videos. Just briefly, a couple tips for the surgeons, and we can talk more, if and when you get to the point of using it. But you want most of your product deep. For inguinal hernia, it's easy because we're putting the mesh in at the internal oblique layer, which is where the nerves are coming around, so that's easy. But if in other abdominal incisions, when that comes up after the expansion of indications, you want most of your product deep. Before you put the product in, put on a second pair of gloves, put the product in, close your deep soft tissue, put the last of your product in, most of it though you want deep, and then take your outer gloves off, because after you put the product in, when you're sewing up the first layer of soft tissue, the suture will pick up a little bit of the product on the suture. So when you pull up your suture, you'll get a little bit of product on your fingertips, which then gets it onto your Adsons and your needle driver. And so your fingertips get a little bit sticky. So if you put on an outer pair of gloves, put the product in, close the deep layer, put the last year product in, then take your outer gloves off so that you've got clean gloves when you're closing the skin. That's a nice tip. So, and you don't want the product coming out through the incision. So I'm going to skip through the bunion. I'm going to skip through the knee. Yeah, go.
Hi,
Say it
I'm
again.
Dr. Allen Reck.
Say it again. Well, let's look. Okay, so the dose of the products is determined primarily by the surgical site, not the patient size or other things, because again, I showed you the plasma levels. It's like 1/10 the toxic dose, so that's not the issue. The issue is you want to put enough product in to cover where the nerves are, but not to have it leak out. If you look, we'll go through some of the adverse event data in a minute, but if you look at the early adverse event data, one of the questions is, does putting a product that has a very low dose anti-inflammatory in it change the healing at the surgical site, and is that a good thing or a bad thing? That's one question. So a lot of the early endpoints for safety were surgical site events: erythema, edema, swelling, so forth. Deep surgical site infection, superficial surgical, so those were all endpoints, right? If you look at one of the very early bunion studies, they were trying to get too much product in, and it was leaking out and getting on the skin, and it gives you just a little bit of redness of the skin. And so that was a question early on, is that infection? Is it superficial surgical site infection? Is it cellulitis, so forth? And it's actually just a product leaking out because the bunion's a small incision. They were trying to put too much in. So you can only put about 2 to 2.5 mils in a bunion incision is the answer, and keep it deep where it belongs. Otherwise, it does tend to leak out when you're closing. Once it was learned that you don't want to try to put too much into the surgical site, and it wasn't leaking out anymore, that minimal erythema was not seen in any of the subsequent studies. And again, we'll go through some of the adverse event data in a minute. But you need just enough to cover where the nerves are deep, and that's it. And so I'll show you the bunion. No other ortho, no other podiatry?
Dr. Zimmerman, I've had the pleasure of working with
Go ahead.
Therapeutics throughout the development of Zen Relief.
Hang on one sec. Can you turn the sound off for this particular video? And I'm going to let it run so she can see the application, and then I'll take your question.
Application of the product now.
Yeah, we are. We're not at the skin edge. Specifically not intended to be. The product shows clinical effect. If you look at the earlier parts of the curves, we'll look at some of the curves in a minute, but if you look at the early parts of the curves, it takes about an hour or two to kick in, and you can see it in the curves. You can also see it in the patients in the PACU. Sometimes when they first wake up from anesthesia, they'll have a little bit of pain, but within an hour or two, they're better without any additional meds in the PACU, and it's kicking in before PACU discharge. Yeah, you'll see that in the curves. It's a good question, and you'll see it because that's about how long it takes to be released. That's a sharp question. Did you see the bunion okay? You good? So I'll skip knee because I guess we don't have any orthopedic surgeons today. Say it again? Sure, of course. Maybe. You can go ahead and bring the sound back up on this one if you would. Thank you.
Investigational surgeons that use the product Zen Relief. I wanted to take you through a total knee arthroplasty and show you the use of the product. As you'll see, the incision is the normal standard incision that's made. The techniques do not change whether you use posterior stabilized or whether you use a cruciate retaining. You go in, you put your implants the way you want. Here you're seeing where they're ready on the cementation stage. You have to lavage. You want to do all your washing first and then dry it. Here you're seeing the application of the product. When you do see them, they'll come in 7mm syringes. So in essence, you're going to be pushing some into the medial side, the lateral side of the gutters here, which is all posterior capsular. This may look like a syringe, but it's actually just a tipped applicator. And you'll see that it gets pushed in the intercondylar notch. You can work around the post. Did not have any problems with that. I use the post typically when I do my procedures. And at that point, you're doing about 3.5 cc's into the posterior capsular area. The remainder of it is delivered through the tipped applicator onto the cut medial edge of the retinaculum and the cut lateral edge. You can see that there's quite a bit. It gives you great coverage. It's spread here with the tipped applicator. You're trying to give as much surface coverage as you can with this. And you can move it around here. You'll have plenty to do that. And then there'll be enough to go onto the opposite side on the lateral edge. Where here we're starting proximal, but it's proximal or distal as long as you're getting the coverage. I think that's the key. And then once you've spread that in there, you'll see in the next couple seconds here, we're going to be moving to the other side of the knee, looking at it from the other side. But once it's been applied, then you do your normal standard closure. I tend to use a big vicryl suture down deep, and then I was using monocryls in the surface. I moved just to a vicryl, but it's whatever your preference is. It will work with either. And at that point, then you have your product's been applied, your layered closure, and at the end here, you do your normal closure with your staples. And then once everything is in place, your normal dressings are applied, and the standard rehab protocols that you employ go from there. And as you'll see, there's plenty of product to cover both of the surfaces quite well. Next is going to be the closure, where they've done the layers, and then here's the staples. And at that point, that is the end.
So I'm a general surgeon, not an ortho, but what my orthopedic surgeons have told me is 2 tips compared to the video. One is you actually want more product in your gutters and less superficial that's in this video. And all of the spreading and so forth is not really necessary. Once you lay it in there, it basically spreads out anyway. So all of that rubbing and spreading and so forth is unnecessary. If you're going to do that, use the tip of your applicator, not your finger, because you're going to make your fingertips sticky, but it's not necessary anyway. So that's tips that they've told me since this video was made. Clinical data, which is the bulk of what we want to go over this morning. So 9 studies. The first 2 studies were looking at the product compared to extended release bupivacaine alone, extended release meloxicam alone. That's the first bunion and inguinal hernia study. That's the data I showed you a minute ago that shows the benefit you get from adding the low-dose nonsteroidal. The next series of studies looked at all 3 surgical sites, bunion, hernia, knee, comparing it to active and passive control. Active control is the aqueous bupivacaine. Per FDA, those patients were kept in-house for 72 hours so they could have serial pain measurements over 72 hours. What the FDA was most interested in was the second and the third 24 hours, not the first 24 hours. Also, make sure that any rescue analgesics that they received was captured and any adverse events was captured. So that was the second tier. The next tier was then adding the product to a multimodal regimen. The first studies were done without multimodal. The second studies were done with. In bunionectomy, it was with acetaminophen and ibuprofen. In hernia, it was acetaminophen and ibuprofen. In knee, it was acetaminophen and Celebrex for the first 3 days, and then ibuprofen. So then that's that series of studies. And then the last study was a real-world outpatient study. So the third tier, where it was multimodal, those were also kept in-house for 72 hours to make sure they capture all the data. That was per FDA. The last one is just outpatient inguinal hernia repairs. Come in, have surgery, go home. So real-world application, how does it work? And the main endpoint in that study was complete opiate-free and no opiate prescription. So primary endpoint in that study is not giving them any opiate prescriptions. So starting with the hernia study first. So this is the product compared to active and passive control, again, in-house for 72 hours. Endpoints were pain compared to active and passive control, opiate use compared to active and passive control, and percent opiate-free. So pain on the y-axis, 72-hour time on the x-axis. So if you get placebo, the gray bar, severe pain in the first few hours, and then it comes into the moderate range over the next 3 days. The green bar is aqueous bupivacaine, standard bupivacaine. So that helps for about 8 to 12 hours, and it wears off, and then that's superimposable with placebo. And then the bottom bar is the product alone, no multimodal, just product alone. And that brings your pain scores from the moderate to severe range down to about a 4 out of 10, roughly. So if you measure the pain in the first 8 to 12 hours compared to bupivacaine, it's still better. If you measure it in the first 24 hours, it's still better. What the FDA mostly wanted to know was the second 24 hours and the third 24 hours, and it shows pain differences in all of those different time points. So with saline placebo in the gray, bupivacaine in the middle, ZenRelief on the right. ZenRelief patients, fewer patients have severe pain at any point in their postoperative course. They use a little bit less pain medication than bupivacaine. About half stay completely opiate-free, and of the ones that were opiate-free in the first 72 hours during the inpatient data collection, at day 10 and day 28, most of those are still completely opiate-free. And again, that's just product, no multimodal, nothing else with it. What are the side effects? The side effects between the product and the bupivacaine are essentially superimposable with two differences. They're essentially superimposable because that's what it is. It's a bupivacaine product. But the two differences are, in one of the early studies where it says skin odor abnormal at the bottom, there was one nurse investigator at one site who could smell the product, and so she reported an abnormal odor. No patients in any of the studies ever smelled it. Actually, there's now about 11 or 1,200 patients in 9 studies. And so far, no other patients have ever smelled it, no other surgeon has ever smelled it, and no other investigators or nurses have ever smelled it. But there was one site, one nurse could apparently smell the product. So that comes up as skin odor abnormal in this study. And then the other minor difference is opiate-related adverse events. Because the patients that get the product use a little bit less opiates, they have a little bit less opiate-related adverse events. And other than that, the adverse event profile is basically superimposable with regular bupivacaine. So the follow-on study, so this is where you add the product into multimodal. So these are inguinal hernia patients getting one dose of, actually this is your comment earlier about preoperative meds. They got one dose of acetaminophen and one dose of ibuprofen in the pre-op holding area 2 hours before surgical incision. Then they got the product in the OR, and then they got their post-operative acetaminophen and ibuprofen every 6 hours. So in the hernia study, so that's the data I showed you a minute ago. The purple bar is just the product by itself. If you then put the product with some acetaminophen and ibuprofen, your pain scores go from 4 out of 10 down to about 2 out of 10, that's where the money is. Because when you get them from a 4 out of 10 down to a 2 out of 10, they use virtually no opiates, right? So that's the money. So it's the combination of the product plus the multimodal. And if you look at the bunion study, basically same study design, there's the data on bunions without multimodal, there's the data on bunions with multimodal. So again, you're taking your pain scores without this product and you're up in the 6, 7, 8 range, whatever. You give the product by itself, you're down around the 4 range. You give the product plus some acetaminophen and ibuprofen, you're down about the 2 range. And that's how you get them virtually opiate-free. So then if you look at the data, so bunion patients on the left, hernia patients on the right, you're now seeing about 71 to 85%, basically 80% of patients never have any severe pain anywhere in their postoperative course, and they use virtually no opiates. So here's your opiate use with bunions, opiate use with hernias. It's the bar on the right, and it's virtually 0. Because by getting them to a 2 out of 10, you basically get rid of your opiates. So you're getting about 80 to 90% of people completely opiate-free, and the vast majority, almost all of those, stay opiate-free after discharge. Adverse event data. So if you're giving now a multimodal regimen, you've got a low dose of meloxicam in your product, you're giving ibuprofen or Celebrex as part of your multimodal regimen. So the question is, by mixing your non-steroidals, are you going to see the adverse events of non-steroidals, right? GI bleeding, surgical site bleeding, GI perforation. The answer is no. So again, there's now about 11 or 1,200 patients that have been studied. So far, no issues of GI bleeding, no issues of GI perforation. But you also have to remember that the dose of meloxicam that's in this product is almost trivially small. It's a very small dose. So no issues on the adverse event for the GI stuff. So the total knee data, this to me is the most impressive. So I mean, I showed you bunion, I showed you hernia. To me, the total knee I think is even more impressive. So you give the product, you give acetaminophen and Celebrex peri-op and then some ibuprofen afterward. And that's the pain that your total knee patients have. They're down in the mild pain category in their whole postoperative course. You're doing knees with pain scores of 2 to 3 out of 10. To me, I think that's even more impressive than the other 2 sets of data I showed you. And so, you ask the patients, what's your pain control? About 90 to 100% say I have good to excellent pain control with product and multimodal. Again, the patients were kept in-house for 72 hours for data collection. When they were discharged at 72 hours, how many patients went home and never used any more opiates after they went home? About 40% never used any opiates after they went home after their total knee replacement. So to me, I think that's even more impressive than the other. So what does it mean? Again, I don't have to convince this audience about trying to get rid of opioids, but the bottom line is if you can take 80 or 90% of your patients or some high number of percent of your patients and make their recovery virtually opioid free, you can get rid of a ton of opiates and all of the misery that comes with that. So the last study, so this is the HOPE study. This is the real-world outpatient inguinal hernias that come in, have surgery, go home. Primary endpoint here was how many can we send home with no opiate prescription whatsoever. So that's the last study. This is the study that I was a PI on. Primary endpoint, no opioid prescription in the first 15 days. So if you're a surgeon, and I'm going to tell you that the primary endpoint in this study is not giving your patients any opioid prescription, your question is, are they going to call me back, right, at midnight or Saturday or whatever, right? Because, a lot of pushback early on. We want you to do a study and not give your patients any prescription. They're like, no, I don't want to get called at midnight. It's not going to happen. I'm going to give them a prescription, and if they don't use it, great, but I don't want to get called, right? So another endpoint has to be callbacks, right? So here are the data. So this is the inguinal hernia. This is the first 100. We've done about another 100, or about 200 now in this study. How many went home without an opioid prescription? About 90%. How many stayed opioid-free? Over 90%. And down at the bottom, how many patients called back later to talk about pain control? 0. And that was in the first 100. We've done about another 100 now. We're at 192 or 196 or something now. Still 0 callbacks. Right? So that's the thing the surgeon wants to know is if I'm actually going to give them no prescription, I don't want to get bugged. And the answer was 0 so far in the study. And the patients do well. They're happy. Patient satisfaction scores, 80, 90%, good pain control. Same thing, if you can get rid of opioid prescriptions, you can get rid of a lot of pills. We do, as general surgeons, we do about 750 to 800,000 inguinal hernia repairs a year in this country. The average number of pills given on a prescription prior to the Michigan database and this study and other recent stuff was about 30 to 50 pills. That's what they were going home with. And so that's a bunch of pills, and there's no reason to do that, right? So you can get rid of lots of prescriptions and lots of pills. You asked about multimodal every 6 hours versus every 3 hours. So the first half of the study, the first 100 patients, half of the patients were given acetaminophen, 1,000 milligrams, ibuprofen, 600 milligrams simultaneously every 6. The ibuprofen and the acetaminophen were alternating every 3 hours. So acetaminophen, then ibuprofen 3 hours later, then acetaminophen 3 hours later. So same dose of drugs, but alternating versus concurrent, and the answer is it didn't make any difference. If you look at the effectiveness and pain relief and the side effect profile, it was indistinguishable. So for the second half of this study, we just said it's surgeon and patient choice because it makes no difference. Last thing, cost, reimbursement, right? Everybody, what's the cost, right? So this is how the product comes. It has the vial with the product in it. It has a little spike to draw it up into the syringe. It comes with a syringe. It comes with a lure lock. All that's in a box. The box is designed to be a size that goes in the med carts, so it's in the med carts. It's stored at room temperature, shelf life 3 years, right? Room temperature 3 years, it's just there. All right, so that's how it comes. What's it cost? There's a big size and a little size. That's determined by the size of the surgical site, not the size of the patient. So big size, little size. The cost of the big size is a little bit over $200. The cost of the little size is a little bit over $100. How does that compare to the other 3, right? So we've got liposomal bupivacaine. We've got bupivacaine in a collagen sponge for inguinal hernia surgery. And we've got pumps and catheters, right? The other 3 delivery devices. So how does it compare? So that's how it compares. So those are the numbers of the others. So the bottom line is this is going to come in, 50, 100, something like that, dollars less per case than your other delivery techniques. And it's the only one that shows clinical benefit beyond 24 hours. The FDA, when I showed you the study design, why did they want all these patients staying in a house early on for 72 hours? Because they wanted to know what the pain relief was from 24 to 48 and 48 to 72. They set the bar that if you're going to call this an extended release, if you're going to use the terminology extended release in your marketing materials, you have to show clinical benefit after 24 hours versus active control. That was the bar. If you look at the other 3 delivery devices, they don't have that. So if you look in their literature now, if you go back now and pull up the website for the other 3 sites, they don't have the term extended release. They use other words because the FDA wouldn't give them that. FDA gave this product that terminology because it showed it out to 72 hours and it showed it against active control, and it's the only one that does that. So the point is you're getting higher relief, longer relief for a little bit less money. So the question is where do you introduce this so that you don't kill your pharmacy budget, right? So two points. One is if you're doing patients that are being, this is not my expertise, but this is what I can tell you. If you're doing patients where the reimbursement for this is going to be in your bundle, as your inpatient bundle, and you're already using bupivacaine, you're already using liposomal bupivacaine in your surgical procedures, if you replace the liposomal bupivacaine with this product, you're using a product that costs less, so that's an easy discussion. The second easy discussion is CMMS has been working with the company since initial approval a few months ago to get a C code. That C code was approved last week. You can go on and read the press release for last week. But Medicare and Medicaid gave this product its own C code. So for patients that are done in an outpatient surgical center, it's reimbursed now by CMMS. And insurance companies most are following, but that depends on the company and the state. So you have to talk to your rep at your hospital. But most of the major payers are following, and for outpatient surgeries at hospitals, not at ambulatory surgical centers, that's also in the works and expected soon. So the two questions about where do I introduce this without killing my pharmacy budget, for your outpatients where it's separately reimbursed, it's reimbursed at the ASP plus 6%, so that's not an issue. Where you're replacing already as your baseline local analgesic, your baseline amide anesthetic and your multirodal regimen, with this, it's being purchased at a lower cost. So if you look at where the adoption is starting over the last couple of months, that's where it's going, because it's not an impact on the budget. So that's the four things I wanted to cover. So the mechanism of action, why this is different, the application, why it's different, no needle with the application, the data, that's the data from the 9 studies, and then the cost issue. So that's what I wanted to cover. GI side effects, I mentioned there's no examples of GI bleeding, GI perforation with this product plus a multimodal regimen. So the FDA still requires the language for warning, but there's not really an expectation that it's going to happen because it's so low dose, and so far it's not been seen. The product is bupivacaine and a baby dose of meloxicam. It's basically a bupivacaine product. So the same contraindications with bupivacaine. If you have an allergy to bupivacaine, don't take it. And then as far as safety information, the main organ system issue is renal failure patients. And again, the anesthesia staff know that better than the surgeons do. But if you're a renal failure patient, a dialysis patient, you don't clear your amide anesthetics as well, and you see higher toxicity. So in all the studies, it was chronic kidney disease stage 3 or less got product. Stage 4 and 5 in dialysis patients didn't get product. So the last thing, has anybody seen this video yet? Gone to the website or seen this video yet? It takes a couple of minutes, but if you haven't seen it, I think it's worth your time, so I'm going to show it. It's why we're here. It's why this organization exists.
This wasn't what I set down in my goals, and I wanted to be able to change the world on the opiate epidemic, right? It's never something I'd ever thought I would be doing. But I do believe with all my heart that God has a purpose for my life and a purpose for our family, and that Tyler didn't die in vain. I'll tell you about Tyler. We'll kind of start there. He's a mega cum laude graduate. He was an all-league, all-county golfer. He actually recorded 2 hole-in-ones before he turned 16 years old. After high school and not playing competitive golf for over 2 years, he walked on the golf team at Walsh University, where he earned a golf and academic scholarship. And then in 2013, he did a bodybuilding show. And at the age of 22, he was announced runner-up junior Mr. Ohio. So I kind of say, how does a kid like that get addicted to heroin? So what happened with Tyler is he had broke his right arm 4 times, and he had 2 surgeries on his right elbow. The first surgery was at age 11, and the second surgery was at age 18. And ultimately, he became addicted to the opiate prescription pain pills. The next 5 years of our life looked like recovery, relapse, recovery, relapse. Tyler could never get a year under his belt. He could get 6 months, he could get 8 months of sobriety, but he could never really get a first year. And so ultimately, what happened with Tyler, on September 28th of 2014. He was in the process of overdosing, and the person he was with, instead of calling 911 for help, he took him to a vacant lot and he dumped him in a field and left him there to die. What do you do when all your hopes and dreams are left in a field to die? How do you respond to that? In this case, the drug dealer was an 18-year-old kid who sold a lethal dose of heroin that was laced with fentanyl that killed my son. So, what do you do? What do you do in that? One of the hardest things I've ever did was to look this kid in the face and tell him I forgive him. When we were in the process of going through active addiction, I didn't understand it. I didn't really understand it as a disease. Thought it was a moral failure, thought I failed as a father. It wasn't until, after Tyler died that I got educated and learned, the disease of addiction. If my son had leukemia or cancer, I wouldn't have sat in silence for 5 years. But because of this, because of the stigma that's associated with this, and there's still a debate on whether this is a choice or whether this is a disease, right? I sat in shame. My youngest daughter was, like I said, 17 in high school when this happened, and he was the third young man who died of a heroin overdose within a year in our community. And so my daughter, with two of the other girls and the guidance counselor, decided to tell their stories in our community. And that really provoked me to say, wait a minute, man. My daughter has enough guts to tell our story. Let's go, man. What are you waiting on? And so I really give her a lot of credit for, one, having the courage and the strength at the time when I didn't. You know what I mean? I didn't. That's when I really realized that I couldn't change the mistakes that I made in dealing with Tyler, and there's nothing I can do to change that, but I can change how I respond and move forward. I get excited when we start talking about alternatives to opiate prescription pain pills. One of the things that I often talk about is pain, because pain is real, and it's real for everybody. And one of the things that I think we have to do a better job of as a society is start to learn how to deal with pain and embrace the pain in our life. You don't have to be real smart to figure out that the overprescribing of opiates has led us to the worst drug epidemic in the history of our country. I don't think you have to be real smart to figure that out. And so I think any doctor who's being responsible will recognize this is a problem. The doctor needs to sit down with the patient and talk about realistic expectations of what's going on. Have that conversation. I never had that conversation. I didn't even know what an opiate was, right? I didn't know what Oxycontin, Percocet, Vicodin, I didn't know what any of that was, right? Now listen, if the doctor would have said, I'm gonna give your son heroin, well, I'd have been smart enough to figure that one out. And so as a parent, as soon as my son or daughter gets hurt and I go to the doctor and he starts mixing opiates, I always say your head should start spinning off. You know what I mean? You should start asking 10,000 questions. And is this necessary, If you got to put someone on opiates because the circumstance dictates, help them get off the prescription pain pill. There's a lot of moving parts in this epidemic. It's not going to be an easy solve. I don't think our federal government's going to solve this. I don't think our state government's going to solve it. I think it's going to be solved in our communities. And it's going to be solved in our communities because people stand up and recognize these people are our neighbors, our cousins, our wives, our family, and we need to respond with love and compassion and get off all of the craziness. And when we start doing that in our communities, that's how we're going to transform this thing. If we can take Tyler's story that's happening all across our country, and if we can do something to offer hope, right, back to people, then that's how this thing's going to start to change,
So kind of intense, but I think it brings home the point. What's the purpose of ERAS, right? Why are you guys here? You're trying to get rid of opiates and make patients recover better, right? So I figured you'd appreciate that. So that's it. It looks like my yellow light came on. I've got about 4 minutes left, but I'll take questions if there are any, and if not, I'll talk to you guys after we're done, get out of the podium. Any questions or comments? Comments or thoughts? Go. Yeah.
So when you change the tip, like I know with other products that we've been operating for, if you stop squirting it, then it clogs it and you have to change
Does not. Does not. You just use it till their syringe is empty. Go ahead. Say it again. Yeah, so there were a few things that came up. I want to say, I can't remember, it was like 3 or 4 or 5 or something like that, and they were investigated through the DSMB and basically determined not to be LAS. There's no LAS now in about 1190 or something patients, something like that. But yeah, good eye. But yeah, there's no LAS in any of the studies. Question or comment? Yeah, so not TAP for hernia, but yes with adductor canal blocks for knees. And the guidelines for the product is you have to give your blocks prior to giving your product, no additional amides for 4 days after giving this product, but you can give your other stuff. And the issue obviously is just be aware of your total dose, right? Because it's going to be cumulative in the plasma. Go ahead.
Yeah, what other indications are there? Because you were a slide about the cost savings on basically on-cue pump.
Yeah.
But the surgeries you have, the bunions, the herniorrhaphy, and other stuff, we don't use a lot.
Yeah, so the indications. So when the product was initially approved in May and launched in July, the data from the 3 models were submitted to the FDA, and the FDA gave them all of those indications. That's the indication right there. So that's what the FDA gave the company with the approval in May, and that's how it launched. So the data was submitted for 3 operations, and it was approved for all 3, but it wasn't given a broader. In October, so 3 months after launch, the FDA and Heron jointly released a statement that said, based on existing data and experience so far, without the need for any additional trials, we're going to broaden your indications. For abdomen and pelvis, it's going to be any small or medium length abdominal incision. And for ortho, it's going to be not only knee, but it's going to be hip, knee, foot, and ankle. And so that was announced last month by the FDA, and that's expected sometime in the next couple of months. So that broadening is going to occur. There's a few other things that the FDA wants to see additional data on for other sites, and so some of those studies have started and others will be starting. They want to see separate data for spine, they want to see separate data for shoulder, and there's no data yet on anything thoracic. And the FDA wants to see data on those before it'll broaden to those. But basically anything else, abdomen, pelvis, lower extremity, that broadening of indication has already been announced, and again, you can read about that. It's public information, and that's probably going to be in the next couple of months. So yeah, it launched with what the FDA launched with, but it's obviously broadening. Go ahead. So it's after. So after you've irrigated, confirmed hemostasis, the last step before you start sewing is put down product. Because if you get into bleeding and further irrigation, you don't want to do irrigation after you've already put your product in, right? So you do your procedure, and when you're getting ready to close, then you put in the product and close. So it's at the very end of the procedure. So now I have a red light. So I'm going to get off the podium. If you guys want to talk, I'll be down here. We're happy to talk with you. Thank you for coming this morning. I know it was early.